I read few of the common points on behalf of us. We have requested everybody.
Sure, sir.
So the clinical examination of shoulder and knee joint, one, understanding and pathology of shoulder and knee joint, examination and clinical findings of the knee and shoulder joint, reading of imaging rather, X-rays, MRI, CT scans of normal and abnormal. Because normal is first, and that is very essential. Yeah. It's like first reading the physiology and then pathology, and criteria for knee joint and shoulder joint. I would like to talk first about Dr. Anmol. And they have a big center, rather I would say near the Nama Hospital at Shankarlil. And there are 5 doctors. They are a team unit. He is looking after knee and shoulder. We had Dr. Yogin, who looks after spine, and Dr. Gaurav is also looking after spine. There is another 2 doctors. One is pediatric orthopedic. They have
Dr. Deepak Jain.
Dr. Deepak Jain, and there is one more
And Dr. Dhruman Sangoi for foot and ankle.
for
Foot and ankle.
foot and ankle.
Okay.
So they have all sports medicine. Like he is looking for major, that is knee and the shoulder. So all of them are having a unit and they are doing extremely well. I have made their testing, you can say, test किया था उनका. My close relative उनको यहाँ भेजे थे. I had a very good experience about referring and then getting feedback that what is the actual problem and how do we see that management of the case is very important. It is not that advising चलो तुम्हारा घुटना खराब है replace कर देंगे. That was the experience at the town when we referred with the back, but that was not convincing to me. So I referred it to Dr. Yogin for a back, same patient, and he has said कि Yogin यहाँ पे ही बैठे उनको back के लिए देख लेते हैं. And then that was a joint consultation, back and knee joint both. And now we are on the conservative line of treatment because that was the background which I thought that this patient doesn't require much of surgery. First, the clinical side, the conservative part should be over, and something left thereafter, they will intervene. So they are surgeon, but that not going directly, jumping into the surgical part, making the first analysis, overview, what is the patient is going through, and then coming down to the surgery. This is true. And their another strength is their individual strength. All 5 together, it's a big strength. And now I think we should hear one of the unique topic which is most burning about us, the total knee joint replacement and the shoulder. Again, both of them are very painful for everybody. And shoulder तो ऐसा है कि the patient cannot sleep at night. Just topsy-turvy, इधर से उधर पकड़ जाता नहीं कुछ. And why it is so common, I think he will give us some light and we'll get enlightened through that. Thank you very much, sir.
So thank you so much for
Yes.
such a kind
Yes.
introduction. So till the time we are being dependent on technology,
Yes.
I'll just start off with 3 very simple things. And sir, you have all of my time for
Yes.
today.
Yeah, thank you very much.
Because my most common adverse effect is when I start talking, I tend to talk a lot. So before I start off, I just want to know how many of us are Ayurvedic practitioners over here, or all of us are homeopathists?
Homeopath.
Okay. So I have been brought up in a completely non-medical background family, and that is in fact true for all of the founders of Alpha Ortho, for
Yes.
that matter. So we have always been on the other side of a consulting desk more than we've been on the side of a doctor, and that is what also pushed us to making this team. We've been working on it, me and Yogen, for the past year or so, and but somehow we worked through the biggest hurdle of doctors, ergo ego, and we could get through 6 more like-minded people. The entire aim of making Alpha Ortho was that orthopedics is a very vague branch. Nowadays, people are seeing pediatric specialists for spine, they are seeing spine specialists for knees, they are seeing knee specialists for your hand. But no doctor wants to let go of patients. So it has inherently become, whether we like it or not, more financially oriented or driven as compared to healing oriented. So our entire vision, entire purpose was that if we have a patient, if the patient requires a hand specialist, he or she will be sent to the hand specialist. If they require a knee specialist, they'll be sent to a knee specialist. Because there's a very common dictum that we've been hearing since we were very small children, that ये doctor ने नब्ज पकड़ के बता दिया कि क्या तकलीफ है. That only happens if you know inherently what is the pathophysiology of a particular condition. That you will only know if you've read extensively about that condition, which is why any specialist will not require as many x-rays, will not require as many MRIs or CT scans, sonography, blood reports, XYZ to diagnose a particular condition. And today's talk that I have actually designed, even though sir had told me that he would appreciate if I added some MRI images, is what I use in my practice. And the first thing that we are actually going to see are most common ailments of the knee and shoulder, and how we can diagnose them without using an MRI, how we can diagnose them without using an X-ray, how we can diagnose them without using any investigation for that matter. Because investigations are always supposed to be an adjunct.
Yes.
They're supposed to confirm your
Mm.
diagnosis. If they are helping you diagnose or you are diagnosing through them, then you are not the doctor, the investigation is the doctor. Right? So this was the entire notion on which we have built Alpha Ortho. All of us follow the same thing, and that is what we aim to bring to suburbs. Because I was practicing in South Bombay for 2 years in Beach Candy, Saifi Lilavati, but because I stay in Malad and then I got married, so had to give time to the wife. So then I shifted my entire practice to the suburbs. But suburban practice and South Bombay practice are two completely different
Yes.
games.
Agree.
And so from first day I felt a little out of place, but then I thought, why not make our own place over here? So the entire talk that I have prepared today is going to take us through the most common thing a patient comes to you in the clinic for. Now, fortunately, because I'm a very avid reader, very avid researcher, I am also very interested in how both Ayurveda and homeopathy work. I have read very extensively about both these things because uh, man has this notion, according to Freud, that what he is doing or what he has spent time doing will more often than not be superior to what others have done. Okay, but everything that happens or lasts through generations will always have a thought behind it, will always have a reason behind it. So things can have different effect in different conditions, but no form of treatment, no form of management will ever be a farce, or it will ever be a bogus or a scam, right? Okay, so knee and shoulder are basically two of the most complex joints in the body, but at the same time they are two of the simplest joints in the body to treat. I always say orthopedics is probably the branch that you need to take if in during MBBS you feel you are the most stupid of your class. Reason being, orthopedics is completely physics. It has almost nothing to do with medicine, almost nothing to do with biology.
Sure.
And knee, despite there being tens of lakhs of articles published online in literature, in our books, in our ancient books, etc., etc., nobody till date knows what and how the knee joint functions. The only thing we've come to know that it is a complex ball and a socket and a hinge joint. So it's basically like putting a ball and socket in your door. It's very difficult to understand how that is supposed to function, but nature has made it that way. Um, that is why one thing that I always tell my patients, and I will tell you the importance of this when I come to talking about the surgical aspect, is that whatever God has made can last you a lifetime. Whatever man has made will never last you a lifetime.
Mm.
So that is why the first mode of management is always prevention, and prevention is the basis. And I'm sorry if I'm wrong over here, but prevention is the basis on which the entire concept of our Vedic medication and Germany's Vedic medication
Yes.
have been built, right? So when it comes to Ayurveda, we speak about Vat, Pitta, and Kapha, right? Balancing all the three things. When it comes to homeopathy, we speak about the three principles of homeopathy: optimal dose, similar law of similarity,
Yeah. Perfect.
and single remedy,
Yeah.
right? So these three are the same things essentially that we are practicing in allopathy as well. But just because it is non-Indian, probably we feel that it is a little more sophisticated. But that is not the case. And why is this important is because we are essentially doing the same things in both the practices, for that matter. I will skip Ayurveda for now, but we are essentially doing the same thing in both the practices, just that we end up cutting people more and going against the laws of nature. So okay, so all right, so good things take time. Let's hope this does not disappoint. Okay.
उल्टा है, ये पॉइंटर देखो ना,
Yeah.
उसका वो निकल
Okay.
गया,
So
कनेक्टर निकल गया.
I am Dr. Anmol Mittal. I am a specialist knee, shoulder, and hip surgeon. I am also one of the only 7 surgeons in Bombay who are certified to do partial knee replacements, and I'm Oxford certified for the same. But enough about me. We'll move on to today's topic. So these are the agendas that I had jotted down till now, or will try to explain it to you. First is differentiating between common shoulder ailments, common knee ailments, decoding the most common things on an MRI that a patient often comes to you with, and whether to replace or not to replace. Starting with the shoulder. So these three are the most common conditions with which a patient will come to you. One thing that is very important in clinical practice is that you don't go from diagnosis to symptoms. You go from symptoms to diagnosis. So everything in life has a story. Now if I give you two books that talk about the same king, one book tells you his entire life story as to how he was when he was a child, how he fell in love with the love of his life, how his love of his life left him when he was young, then he won her back, he captured XYZ kingdom, he lost them, then he came back, captured them again. Will that be more enticing, or a history book from your 10th standard telling you that so and so king conquered so and so in year so and so? Is the first thing, right? So stories are always something that catch your attention. Similarly, every disease, every patient has a story. So when a patient comes to you, the worst thing you can do as a clinician is tell them, show me your x-ray, show me your MRI. The first thing, you sit them down and you tell them is, tell me your story. The art of history taking. So story is what is going to give you the diagnosis in 90% of cases when it comes to the shoulder. The rest 10% is clinical examination. MRI is zero. So MRI in shoulders are only used to plan surgeries, for nothing else. And how do we reach that stage is what we are going to see today. Okay. So the most powerful word in English language is why. Till you know the why of something, you can easily deal with it. Okay. Be it tantrums of your partner, be it your child's tantrums, be it the disease, anything for that matter. Okay. So these three conditions, generally the patient will present with the same complaint: shoulder is paining, unable to move, unable to do daily life activities, right? How do you differentiate between a cuff tear, a cuff tendinosis, and a frozen shoulder? The meaning of each is in their names. One is a tear, one is an inflammation, one is restriction, right? So coming to a rotator cuff tear, the patient will classically tell you or give you a history of an inciting incident, which will be very specific. It will never be vague. Patient will remember that I got hit by a somebody while I was holding on to the bus, or I fell down, or I lifted something heavy. Because a rotator cuff tear always starts with an acute sharp pain. That is not easy to forget. Okay. Second and most important sign coming to clinical examination is, so your 90% diagnosis is right there. And the second thing is, pain increases when I sleep at night. Okay, so this is something that you can just highlight and keep. No other condition in the shoulder will have this complaint. Most classical way of diagnosing is the drop arm sign. Drop arm sign essentially allows you to take your shoulder in internal rotation. Your rotator cuff, whenever it gives you pain, they are not essentially abductors. It's a combination of abduction and external rotation, which is why, on contrary to the lift off sign that we see used for subscapularis tears or rotator cuff tears, we use a drop arm test these days, in which you put the arm into the opposite position. Okay, this very interestingly follows homeopathy's first law, law of similarity, because this is how the patient gets the injury: abduction and internal rotation. That is how the patient gets injured. So you make it provocative, you repeat the mechanism of injury, and then you ask the patient to fight against it, right? Keep your hand on top of this, resist it from behind, ask them to lift it. Now rotator cuff tear, there'll be sharp shooting pain, not possible. rotator cuff tendinitis, there will be some resistance and then there will be pain. So that is the classical difference. So what I have changed in my practice, although books say that rotator cuff tear and rotator cuff tendinitis are two exclusive conditions, for clinical tests, they have only written about rotator cuff tear, not tendinitis. So we differentiate two very classical tests. One is a drop arm sign and second is an empty can test. Now essentially empty can test we always associate with the rotator cuff tear. But the empty can test can also be used for tendinitis. How? I just told you. If there's resistance, some amount of cuff is intact. Right? So that rules out a complete tear. But at the same time, it means that there is a pathophysiology or something wrong going on inside the rotator cuff. These are the two most common conditions with which patients will come to you in your clinic. Right? Now, coming to the most common shoulder condition which affects Indians, frozen shoulder. So the most common mistake that we tend to do is the diagnosis that we write after checking a patient who tells you that she is unable to make her hair, unable to wear a sari, is that we write the diagnosis as frozen shoulder. Frozen shoulder is never a primary diagnosis. It is always secondary to some other condition. Second thing that we feel is that it probably might not be true in your case considering all of you look pretty experienced, is that diabetes causes frozen shoulder, right? Hypothyroidism causes frozen shoulder. Autoimmune conditions cause frozen shoulder. No, they are not cause of frozen shoulder, they are associated with frozen shoulder. So the difference between causation and association is causation is what brings it to that from the start to the end. Association is that both of them tend to occur together or are there together. How do we remember? Again, why? How do we remember that they are associated? If a patient has diabetes, patient has hypothyroidism, patient has an autoimmune condition, what is the most common thing in all of these? Patient's anti-inflammatory drive goes down, their healing capacity goes down. So if there's any injury to the shoulder, if a person without these conditions takes 2 weeks to heal, a person with these conditions will take 4 weeks to heal. Within those 4 weeks, if you tend to have another injury, even though it may be less in impact compared to the first injury, the cycle repeats. So when the inflammatory cycle keeps going on and on and on, that is what leads to frozen shoulder, right? So if you see the rotator cuff tendon that goes very beautifully from over the joint, attaches on the top of your humerus, if there is any kind of a tear or any kind of inflammation, so rotator cuff tear, rotator cuff tendinitis, both of these the body responds in the same way by sending inflammatory cells because the body wants to heal it. The inflammatory cells eventually, because they don't get time to heal, will with gravity descend from here to the inferior anterior part of the capsule, and that is the part that is first involved in a frozen shoulder and the last to heal in a frozen shoulder, right? So if we just compare a normal and a frozen shoulder from the front view, antero-inferior part is the capsule that is always inflamed first. That is why a patient cannot do external rotation, and external rotation is also the last movement to go. So frozen shoulder previously in terms of treatment, what was the most common is that they would take you inside the operation theater, they would put you under anesthesia and they would do move up, manipulation under general anesthesia. Now except for probably kids of our generation, nobody else likes to be manipulated anymore, right? So what we do at our clinic at Alpha is we just give a steroid injection in the shoulder. This is the only condition in joints for which we give steroids. Okay, again, the reason being the why is the inflammation. Okay, if the limitation of movement is not beyond 30 degrees, physiotherapy is more than enough to deal with frozen shoulder, along with oral anti-inflammatories. Knees and shoulders don't require painkillers for any condition. Anti-inflammatory, physiotherapy, you're back as good as new. If the restriction is beyond 30 degrees and the patient is in the acute phase where there is still inflammation, is when we give the steroid. So steroid still is not the treatment. It is just the facilitator. The treatment is still physiotherapy. Whatever man can do by himself naturally will always be the treatment, not what we do to them. Okay, so that is why we say we cure, God heals, right? So anything natural will always be the treatment first. Till now, we have treated over 1,000 frozen shoulder patients, me and Dr. Dhirav together, and we've never had to give even a second injection. We have our own protocol for frozen shoulders, generally anywhere between 7 to 11 sessions, patient is back to normal. We'll show you a video regarding the same. So, okay, no problem. So we don't have that application. I can show that to you later. And second is rotator cuff repair. So rotator cuff repairs, again, when to do, when not to do. In young patients, partial cuff tears will always be more painful than a complete cuff tear, because you can still move your hand despite the cuff tear, right? In older people, complete cuff tears will definitely be more painful than partial cuff tears, because they're not going to move their hand as much. So it is completely based on patient's requirements, what pain they are going through, and what are their expectations. That is how you decide. If the expectations are low, it is a non-dominant hand, you can just conserve it. Over a period of time, the pain comes down. If the expectations are high, if it's a dominant hand, if it is an athlete, then you have to get them back to normal life as soon as possible. Those are the only cases which you need to operate. Okay. So before I start the knee, any questions regarding the shoulder?
Clinically, can we see that? If you can see, just make a demo that.
Yeah, sure.
Shoulder, clinically, how we see. I'm a dummy patient. That way you can.
You can stand, sir. You
Yes,
can stand.
Thank you.
So the first thing in shoulder that we always ask is whether it is your dominant hand that is affected or it is your non-dominant hand that is affected.
Okay.
Because unlike the knee, you unjudiciously use your hands, right?
Mm.
First dictum of any examination: examine the normal side first.
Mm.
Okay, you see and you compare.
Mm.
Anyway, we love comparing. So the normal side, you first take it into abduction, check for the external
Okay.
and the internal rotation.
Right.
If the patient tends to give you resistance, just use the elbow to
Okay.
as a fulcrum. Okay, like I told you, orthopedics, stupid branch, biomechanics
Mm.
and physics. Okay, the second thing you do is align your hand in line with your scapula,
Yes.
because scapula is from where all your rotator cuff muscles
Mm.
start. So just take it slightly in front
Mm.
and law of similarity,
Okay.
internal rotation. Okay,
Mm.
ask the patient to hold the hand over there and just give resistance. Ask them to lift their hand up, go up.
Mm.
If you feel a resistance
Mm.
and then pain, it is tendinitis. If you don't feel any resistance,
Yes.
you can just take the hand down, there'll be sharp shooting pain.
Mm.
Okay,
So this is tendinitis.
this is for both tendinitis and cuff.
Okay.
So that is how you use. If the patient has a cuff tear,
Mm.
they will compensate with their upper body. They will take their
Okay,
hand
like
up
this.
like this,
Okay,
which we
okay.
call as cheat movements.
Right. And then the last one, the frozen shoulder, as you said.
Frozen shoulder, as you go over here, you will not be able to rotate at all.
Okay. Okay.
So you have your diagnosis in your
Thank
first
you.
exam. Okay. Now there are some conditions of the shoulder, more so just one condition, in which the patient will come to you with unbearable pain, that they want something right now, or you cut off my shoulder. I have not slept. It started suddenly from last night. No history of trauma, no diabetes, no thyroid. Perfectly fine patient. Overnight has so much pain that it reminds her of her labor pain. That is a very classical diagnosis of a calcific tendinitis.
Hmm.
Okay, so that is the only emergency you can have in a shoulder other than a dislocation. Okay, dislocation तो आपको मेरे पास ही फिर भेजना पड़ेगा.
Just one
Yeah.
question, but why did you say that MRI is useless?
So every single clinical examination for shoulder has over 90% sensitivity and 85% specificity. So clinical examination and history together will almost always give you the diagnosis in shoulder. Any shoulder patient that comes in front of you, you can diagnose without an MRI. Very easy.
Any management part you would suggest? You said one about the anti-inflammatory and the steroid injection. Very
Yes.
rarely you will go for
And
it.
physiotherapy.
And
Yes.
the exercise will be physiotherapy
Yes,
part.
and second, a very important point when it comes to knee and shoulder is never do physio in pain. Let the
Yes,
pain
yeah.
come down to less than 50 and then you do physio. Otherwise, you will end up irritating the joint, it will become angry, the
More
inflammation
inflammation.
increases.
Yes, that's nice.
So, tendinitis, rotator cuff tear, just give anti-inflammatories. Let them ice the joint. No heat on joints ever. A joint should always receive ice. Okay. Muscles, when it is a chronic pain, should receive heat. Generally, then you would ask me that we have somebody we know who has knee arthritis for years, they apply heat on the knee, they feel better. The only class of population that will feel better are patients with autoimmune conditions because they have cold intolerance. And the reason why people who do not have these feel better is because the heat that they're applying is also going to the muscle down and up. So the brain gets confused for the few seconds that the heat is applied. After that, inflammation increases, pain increases. So even in chronic knee arthritis, ice the knee, heat the muscles. Always. Okay? Can we move on?
Yeah.
So coming to the knee, these are the two most common conditions in young people, ACL tears and meniscus tears, right? The third most common condition is seen generally between the age group of 42 and 52. That is a root tear. Again, root tear, no MRI needed. Patient will give you a classical history. I was walking up the stairs or I was dancing in a sangeet. Suddenly my leg started paining. I couldn't bend my knee also beyond 90 degrees. A root tear patient, as soon as he or she walks into your clinic, you can diagnose within 3 seconds before they sit down on the chair. It is that classical, same as calcific tendinitis. But the treatment of a root tear is the most interesting part, which is why I have kept it in the discussion and which we will discuss last. So, coming to the ACL tear first, this is what all my patients get. And if you ever see any of my consulting paper, there will always be a small diagram. Okay, so this is your thigh bone or your femur, this is your leg bone or the tibia. Where the two bones meet, there is a very thin layer, right, which we call as the articular cartilage, because bones inherently are rough, they cannot move against each other. Cartilage is what helps them move. Okay, because the bones are free floating, it needs to be held together. So there are 4 ropes, one in the front, one at the back, 2 on the sides. The ACL, the PCL, MCL and LCL. The gap between the two bones, doctors colloquially like to use this term कि आपके घुटने में gap आ गया है. In fact, gap आ गया है सुन के खुश होना चाहिए. So that gap is not empty. There are 2 cushions that act as shock absorbers, the same way you have shock absorbers in your vehicles, in your cars and in your bikes. Because your entire weight gets transferred from the 2 points on the femur to the 2 points on the tibia. Cartilage is the only part of the knee that has nerves. Meniscus, ACL, PCL, LCL, MCL, they don't have nerves. Even if they get damaged, for 15 to 30 days, there will either be pain or swelling. Even if you don't do anything, it will go away because there are no nerves. So this is where actually quackery has set in quite a lot.
Right.
Because there are people who are posing to be trainers and physiotherapists and they tell them meniscus tears, you don't need any treatment and come to us within 1 month, we will make you okay. Even if you don't go to them, you will be okay. Okay. Now, when and how do you treat ACL tears is again something that we will discuss today because it is something that needs discussing in today's orthopedic scenario. But first, we will come to how do you diagnose an ACL tear. Okay. First thing, again, history. If the patient tells you that while walking, there is instability, I feel like my knee is not supporting me, that is the first sign that patient has a inherent instability. Now, instability can be because of either the ACL or the PCL, but PCL generally is a very strong ligament. It will almost always be associated with something else also. So, instability will not be the first concern of the patient. Okay. So, if this is the knee, how you look at it from the front, a better version of my drawing basically. So, if I just turn this to a side, this is how it looks, right? And this is the main view on the MRI as well. That is a sagittal view. So if we just overlap this view on the MRI, there is your femur, your tibia, the ACL and the PCL. Now, generally on MRIs, you will see at least one slice, at least one cut where there will be continuous fibers of the ACL from the femur till the tibia. Okay, that is essentially there is some part of the ACL that is intact. That does not mean that the ACL is completely intact. Okay. This is a classical picture of an injured ACL. So this is a mid-substance tear, a femoral tear or tibial tear. Can anyone tell me?
Femoral is attached.
Yeah. It's tibial.
Distal part of the ACL is it?
Okay, so one pearl, the ACL will never tear from the tibia. It will almost always tear either mid-substance or from the femur because it has a very wide attachment on the tibia. So even if it tears, it will take a part of the tibia, which we call as the tibial avulsion of the ACL. Okay, femur, because it starts or originates from 2 points, it basically gets divided. Any person, any community that is divided will always fail first. So femoral end is the most common part from where the ACL gives away, or it is the mid substance in cases of elite athletes. Okay, so whenever there is complete disruption, you don't see a single line that connects from the femur to the tibia, you know that the ACL is torn. Again, that is not your diagnosis. For ACL, the most important thing is whether the knee is dependent on it or not. 13 to 15% population is not dependent on the ACL. How do you come to know? Two things: subjective instability. Subjective is what the patient tells you. Second is objective instability. Objective instability is what you check for yourself. Okay, so if both of these are true, patient's knee is dependent on the ACL. If the ACL is torn, the patient has no damage to the cartilage, please get a new ACL. Reason being, not because we want to earn money, we want to save the patient from a knee replacement. So I come back to the first point I made: whatever God has made will always last you longer. So if what God has made is still intact, try to protect it. Okay, now coming to the meniscus tears, you've got two meniscus, the one on the inside, one on the outside, right? And before I go to that, we have a new instrument now which we use at Alpha Ortho. All our ACLs are done by a technique that we call as the all inside technique, in which we don't drill a complete tunnel in the tibia anymore. So for that we need something called as a flip cutter. There are very few surgeons in India who are using that method because it has a few extra steps basically. But the advantage is that we save 70% of the bone in the tibia. Pain is less, recovery is faster. If God forbid patient requires a repeat surgery for anything ever again, it need not be two-staged. So you don't need to fill the tunnel first and then do a second stage surgery. So it is it's basically going on throughout Europe, throughout NHS, everywhere they're using all inside. But unfortunately, India, because of a lot of regulations, we are the last to get all medical advances. So fortunately, we have that, and we've been using that for the past year and a half. And our physio team, basically what they do is we do prehab for all patients, which I will also explain in detail later on. And we personalize grafts for the ACL. We don't use hamstring for everyone or peroneus longus for everyone or quadriceps for everyone. We personalize the graft based on the prehab proforma that they fill. We find which graft will be best suited for them, and then we go ahead with the surgery. Okay, so we'll talk more about that later. Coming to meniscus, these are the most common things in India that a patient comes to you with knee pain. Also very notorious to manage because sometimes patient comes with you with intense pain, there's a lot of swelling, we end up aspirating the joint. That is what most commonly that is what allopathic doctors actually tend to do more commonly, right? But no meniscus tear requires aspiration. Even if there is a swelling secondary to a meniscus tear, it will subside, like I told, within 15 to 30 days. Anti-inflammatory is icing. No rest required. Let the patient do whatever their daily life allows them or whatever their body allows them to do. Okay, we've gone beyond that stage in which we can tell the patient that, okay, you've got this problem, rest for 10 days. Nobody's going to listen to you.
I think even in the spine, he was insisting on that not bed rest now. and something like they have been mobilizing very
Right,
fast
right.
too. That's a very good thing. In a faster life, today's life, people need like that.
So the thing is, sir, that any condition of the body, irrespective, human brain has been wired in a way that majority conditions or problems will happen after you cross the age of 30, 35,
Yeah,
40.
yeah,
Now you're living your life in a certain way for so many years. If somebody else, especially somebody younger than you, tells you that no, you cannot do this anymore, it will be difficult for them to
yeah.
follow it.
That's right.
Probably I'll be the same way when I turn 50 or 60.
Yeah,
Okay. So medicine is not supposed to force somebody to do something or not do something or modify their life essentially. We need to find a way in which they can continue doing what they like, but without the pain or what is
yeah,
causing them
yeah.
to hold back. So coming to meniscus tears, middle meniscus, lateral meniscus, the most easy way to find them on the MRI is an axial
Yes,
plane. I will just superimpose an MRI image on this.
yes.
So that is how your menisci look on the
Mm.
MRI, the medial and the lateral. The other cut, the two other cuts are actually more important for the meniscus. This is actually the most useless cut for a meniscus. And we come to the coronal cut. So coronal cut is basically when you're looking at the knee from the front and making multiple slices of the knee. So you go from the front to the back of the knee. Any cut in the coronal image will always give you the slice of the meniscus, right? So what do you need to look for in an MRI, irrespective of what the radiologist reports, is what I will tell you today, because that is the only part that is important. Okay. So the two small black triangles that you see are the menisci. In any coronal cut, these triangles will be maintained from front till the back, except at the back they become a straight line. That is the root part of the meniscus. This is a sagittal view. Again, two triangles, but the easiest way to differentiate them is the posterior triangle will always be bigger than the
Yeah.
anterior triangle. Okay. Now, if I show you this MRI, can somebody tell me whether it is normal, abnormal, whether it's a meniscus tear, whether there is no meniscus tear? Patient comes to you, 28-year-old male, pain and swelling in the knee joint, history of climbing stairs, twisting his knee while he did so 4 days back. And people are very smart nowadays, they get MRI done by themselves.
Yeah, yeah.
So how do you manage? This is going to be a very, or probably already is a very, very common picture in your practice.
Right.
So is there a tear in the meniscus, do you think?
We need to learn from
So
you.
easy way to diagnose is always see the T2 image first. Okay. T2 image, remember the mnemonic World War II. Water is white on 2. Okay. Water in the knee is abnormal.
Yes.
Anywhere there is white in the knee, it is abnormal. Simple. We'll do reverse racism over it. So there is a small white line that you can see inside the triangle on the back side
Right.
of the meniscus.
Yes.
Basically, there is no meniscus substance over there, so water has seeped in. Wherever there is a tear in the knee, water will seep in. Wherever there is a tear on the shoulder, water will seep in. Okay, very easy to diagnose even on MRIs. So there is a tear in the meniscus. Now, how do you approach this patient? What do you tell them? Would you, okay, raise your hands if you feel that the patient can be conserved based on this MRI.
It looks very likely.
Sorry?
Very likely conservative.
Conservative.
Yes.
Okay, reason being?
Reason is the effusion, as you said, in 1 or 2 or 3 weeks it will get absorbed.
Right. So the meniscus has the job of being a cushion,
Cushion.
right? So it essentially is the first protector of the cartilage. If a meniscus tears, it's like the tear in your shirt, in your t-shirt, or in your sari. The more you wash it, the more you wear it, the size of the tear increases. Similarly, a meniscus tear in situ, the more you use it, the more you jump, run, jog, the size of the tear will increase. Every time the size of the tear increases, pain and swelling will come back for 15 to 30 days. You rest, it goes away. Nothing happens for 6 months. Again, you run, you jog, it comes back, the tear increases. This keeps happening till the time the meniscus completely stops working. And that is when both the bones, because there's nothing in between, both the bones start coming close to each other. Eventually they touch, and when you walk on them, when they touch, they rub. That causes damage to your cartilage. That is what requires a knee replacement before you turn 60. So the most notorious common cause of knee replacements in India, I consider knee replacement essentially as a disease. Okay, because it means that you have to get a treatment for something that is incurable. So the main cause is neglect of a meniscus tear. Now the advantage that we have at Alpha Ortho is that all of our joint surgeons are neither just scopy specialists nor just plasty specialists. We do both. So that helps us to know in which patient we need to do which surgery. Can we do scopy in one particular patient? Can we do plasty in one particular condition? And more importantly, which patients to just leave as it is.
What is plasty, sir?
Plasty is replacement.
Replacement. Okay.
Okay. So this patient, if he's 28-year-old, I would conserve him, I agree. But the reason is not because that the symptoms will go away. The reason is because the tear is not extending to any articular surface. So articular surface is either the top end or the bottom end. Till the tear is constrained or contained, it will not increase. Okay. So
Can you
if
see the tear? Is it
yes. So this is the tear.
visible?
This. Oh, perfect. So this is the tear. Can you see this?
Yes.
The white line. This is how a normal meniscus looks. It will be completely black. And this is the tear. So the reason I will conserve this patient is because it's a contained tear. This is the patient that you operate. Right? Because the tear is extending to the articular cartilage or the articular surface. And these are the kinds of tears that will lead to osteoarthritis. Now, if you get a 62-year-old patient, knee pain on and off for the last 4 years, suddenly the knee pain has increased after a twisting injury, comes to you with this picture. Do you operate? Do you not operate? You don't operate. Again, reason being, generally people this age will have some or the other damage to their cartilage. If cartilage damage has already set in, but it is not so bad that it requires a replacement, you conserve these patients, because if we go in, we repair the meniscus, irrespective, the pain is not going to come down beyond 50 to 20%, because like I told, cartilage is the only part of the knee that has nerve. If that is already damaged, there is no point doing this. Okay, so that is a little advantage that you have when you understand the both concepts of arthroscopy and arthroplasty. And this is where it gets the most challenging, these kinds of patients. If patients with root tear, like I told you, if you remember, extremely painful, can't bend the knee beyond 90 degree, want some intervention immediately to get rid of the pain. If such a patient goes to a scopy surgeon, they will do a scopy, they will repair the root. If you send it to a plastic surgeon, they will do a knee replacement, right? But the decision for this needs to be made. Now is the role of both MRI and the X-ray. So MRI essentially is going to give you the diagnosis or confirm your diagnosis, but X-ray is what will decide your treatment. So if along with the root tear, there is no space in between, if the patient has bone-on-bone arthritis, logically speaking, even if I repair the root over here, there is going to be no space over there. Eventually, it will give up because of the stressors. The operation is deemed to fail within 6 months. So these patients, again, now the dilemma starts. Only 30% of the knee is involved. Rest 70% is normal. So what do you do? And this is where our third strength or our USP comes into play. If there is no bone-on-bone medial compartment arthritis, we do scopy, we repair the root. If there is, rest of the knee is normal, we do a partial knee replacement. And this gives brilliant results irrespective of what notion that people tend to have in mind, because we have published a paper that has highest number of patients of partial knee along with the longest follow-up in India. So we just published it last month, and what we have seen is the most common cause for failure in cases of partial knees is wrong selection of patients. So it's very important to know which patient you do a partial knee, which patient you don't do a partial knee. The main advantage of a partial knee is a small cut. You are not touching the rest of the 70% of the knee. Pain is less, recovery is fast, and most importantly, for Indian population, there are no restrictions. Patient can sit down, they can squat, they can do everything that they want, because 70% is nature and we are there only 30% to support. Okay. More importantly, if you have to do a total knee replacement at the age of 50, 55, patient will require a revision by the time they are probably 70,
Yes.
right? A revision knee replacement will not have life of more than 5 to 8 years
Mhm.
because there's a lot of bone loss inherently. After a UKR, if we revise it to a TKR, it is as good as doing TKR for the first time. So the life is again 15 to 20 years. Basically, patient will never need another surgery in their life. So that is where UKR becomes a lifesaver for people between the age of 45 to 55, especially that have bad middle compartment OA. And according to a lot of papers from India, although there are very few, but all those papers state that more than 50% of the Indian population that is undergoing total knee replacement actually requires only a partial knee replacement. And that is why 20 to 23% patient population is not happy after a total knee replacement. And there are two other factors to which I will come at the end of the presentation. So the most common dilemma, when do you replace? It is, you don't have to treat an investigation. You don't need to treat an X-ray. You don't need to treat an MRI. This is not a life-threatening condition. It's not a problem of the heart or of the kidney. This is a lifestyle condition. So you treat it only if the patient's lifestyle is getting affected. If the patient comes and tells you, मुझे तो सुबह उठना होता है, खाना खाना है, टीवी देखना है, सो जाना है, मेरे घर के सब काम या तो मेरे नौकर चाकर करते हैं या तो मेरी बहुएं करती हैं. Leave the patient alone. उनकी बहुओं ने भी उनको छोड़ दिया है. Because irrespective, even if you do the surgery, the most important part of the surgery is the physiotherapy. It's not the surgery. Anybody can do a total knee replacement. It is one of the most easy, mechanical and stupid surgeries. Okay, but again, what defines results is patient selection. There are a lot of patients who come saying that एक घुटने का करना है, आप दोनों का कर दो, अंदर ही ले रहे हो तो. That patient will never be happy, right? The reason is next, and these are my non-negotiables when it comes to to deciding whether or not I will operate that patient. One, the knee is ready for surgery. That means the knee is so bad that patient will feel relief after the surgery. And second and most important, patient is ready for surgery. Family is ready, family forces does not matter. Orthopedic surgeon forces does not matter. Family physician forces does not matter. Till the time the patient is not ready for surgery, do not touch the patient, because again, the only treatment for pain after the surgery is physiotherapy. If the patient is not motivated, they will not do physiotherapy. They will tell you, मुझे सर्जरी नहीं करानी थी, आपने ज़बरदस्ती करा दी, अब मुझे दर्द हो रहा है, मैं कुछ नहीं करूँगा या मैं कुछ नहीं करूँगी. And you get stuck in that negative cycle. Okay, so आप नहीं करोगे तो कोई और कर देगा, या मैं नहीं करूँगा तो कोई और कर देगा, is never an indication for a total knee.
Yes.
Okay, and these 2 points are the main points why 20 to 23% of the population is not happy after total knee replacement. Either the knee was not ready for surgery or the patient was not ready for surgery. Okay? Of course, 4 to 5% हमारी भी गलती हो सकती है, but generally knee replacements are a very forgiving surgeries. For the first 2 odd years, patient will have no complaints. They will feel that the surgery was done brilliantly, their life has changed. Then the problems will start.
What are those like?
Yes. So
After 3-4
anything,
years.
if there is any malalignment, if the knee is not balanced, the same way like you need balancing of Vat, Pitta and Kapha, you need balancing of all your ligaments. So until the knee is not properly balanced, you are going to have aseptic loosening. If you do not maintain dictum in the OT, so we always use hazmat suits, we use helmets, we do not open a joint without helmets. We are very strict in terms of the hospitals that we operate in the suburbs. We do not operate without a laminar airflow that is more than 20 square meters, because
Yes.
we need all our instruments below it. Infection is the worst enemy in orthopedics. I think Dr. Yogen is going to agree with me, because
Yes.
once any part, a bone is the deepest part of your body essentially. And if there is infection in the deepest part of your body, it can ruin your life. So we always prevent it rather than trying to cure it. Now, regarding knee replacement, the most common question I get asked is conventional or robotic. I think this is probably another question that all
Yes.
of you will be having. So when it comes to the knees right now, the robots are primarily like influencers. Uh, they are good to look at, but they're of no use.
Hmm.
So they are more of guiding materials or an extra assistant that can guide us. Essentially, the surgery is still being done by the surgeons. Unlike Da Vinci, that is used for gastro, cardiac, they are proper robots. You can actually get micro dissections and all out of them, which our robot do not do. The only place where knee replacement robots are actually useful right now is if you're using a different kind of alignment system. So the most commonly used is the mechanical alignment. If you see the X-ray, the tibia will be cut at 90 degrees. There are many more philosophies of alignment like kinematic alignment, restrained kinematic alignment, functional alignment, in which you try to restore the knee to already what it was. So the X-ray will look very ugly. You will feel that surgeon ने वापस इसको arthritis ही दे दिया है. But those are different philosophies that we are working on right now. Like I told you that we still don't know how the knee joint works and what is the perfect treatment. So those are, if you are following those philosophies, the robot can help you to a certain extent because it gives you the right angle whenever you are taking cuts. But uh, the notion that robot improves results is completely wrong. Again, we have our own paper of more than 200 patients. The only difference was in the first 2.5 weeks where the patient felt a little better after doing a robotic, and the reason for that was placebo effect. Because they can go out to their cousins, to their family, to their kitty parties and tell that I got a robotic knee surgery done. But after 2.5 weeks follow up, all the results were exactly the same. So until and unless you want that those bragging rights,
Yes.
don't do a robotic knee replacement, at least for now. So I don't push any patient. Me and Dr. Dhirav do robotic knee replacements, but we don't push any patient for a robotic until and unless they tell us that they want to do that only. Okay.
Sir, can you please again tell me the exact indication for, say, a unilateral or a half?
A partial or a full. Okay.
partial?
So generally when patients come to you, they will come in a virus. That is more than 73%, 74, 75% of
Yeah.
population. Whenever you examine the patient, you do a valgus stress test. You take the knee in 20 degrees of flexion. Keep your left hand just above the medial epicondyle and give a valgus force. If you see that the knee corrects, if there is no lateral joint line tenderness, if the patellofemoral grinding is negative, that means that only 30% of the knee is bad. And then on the X-ray, you get a picture like the one on the left, that it is only the inner part that is bone on bone. So these are the cases in which you do a partial knee replacement or a unicompartment knee replacement. Now there are criteria in addition to this. After the patient qualifies for this, it involves inflammatory markup, rheumatoid arthritis, ankylosing spondylitis. We have started adding ANA also, although it is not there in Oxford's regimen, but we've started doing ANA also because it is more prominent on the west coastal belt of India. So now any ANA 2 plus patient we do not do. Uric acid, if any of these is positive, a partial is eventually going to require a total. So then,
that is the whole thing. I'm just sharing.
yeah,
my
no,
clinical
definitely,
experience.
definitely.
Yeah, because in past 2 years, say probably I would have met about 15, 18 patients with half which are done, and none of them were happy. It's like कि हमने पूरा ही करा लिया होता है या हमारे डॉक्टर
Yeah.
ने कराने के बाद बोला अरे पूरा क्यों करा?
So I will share my paper with sir. A part of our paper also includes why patients told no for partial knee replacements. Okay, and the main reason for that was either their second opinion orthopedic surgeon said no, who does not know how to do a partial knee replacement, or somebody in their family who is a doctor told no, and the patient thought कि आधा करा ही रहे ऐसे तो पूरा करा ले. Okay, so actually the idea behind a partial knee replacement is that if you are offloading the medial compartment, then disease should not spread to the lateral compartment. We have had patients who've got partially done 18 years back also, who have never required a TCAR. But the reason why we do the inflammatory markup is because if you have an inflammatory condition or an autoimmune condition, it will definitely spread to your lateral compartment. So homeopathy's minimal dose or single dose idea fits into that. That if you want to operate, try and operate only once. So if you know that for sure, if you are doing this, patient is going to require a surgery later again, don't operate.
So even in elders, we can do a partial.
Yes, 100%. In fact, in elderly age group, it gives even better results because we save more muscle. So the main dilemma is generally in patients who are between 65 to 70, you tend to feel that if we do a partial now, अगर 10 साल बाद fail हो गया तो 80 की उम्र में टोटल कराना पड़ेगा, इसे तो अभी टोटल कर देते हैं. Okay. So that is the main dilemma, and that is why it is very very important that your patient's partial knee is being done by an Oxford certified surgeon, because patient selection is everything in this. If you select the wrong patient, you are never going to get result. It will fail within 1 to 1.5 years.
Go.
Yes. So now the last part is how we've integrated physio into our alpha team. The philosophy that we follow is something that is not followed anywhere in Mumbai except two surgeons in South Bombay. So I will not name them for obvious reasons, but uh, prehabilitation is the part that is most often overlooked by surgeons. A surgeon will most often meet patient one when they try to convince them for surgery,
Yes.
and then two directly inside the OT,
Yes.
and then third probably never.
Hmm.
So
No, I do refer them back because patient keeps on complaining. मेरा तो घुटने का दर्द गया ही नहीं.
So one thing that we have learned is FaceTime with a doctor by itself acts like a medicine.
Hmm.
Okay, the reassurance.
Yes.
And that is why what we have been practicing at Alpha is that we always combine the physical aspect of a patient with the mental or psychological aspect. Our physios have been trained in a way that whenever they are doing the rehab, whenever they're doing the prehab, they get all the information out about a patient's personal life, their office life, if there is some problem, because primarily the patients we deal with are either very young or very old. So they are either financially or emotionally dependent on their children or on their parents. So they very often act out, they try to show that they have pain when there is nothing. And then you sleep at night tossing and turning thinking कि surgery में कुछ problem हो गई क्या? And then your wife shouts at you, why are you not sleeping? Let me sleep. So that is why the way we function is that during the prehabilitation phase, we do three things. First, we have a proforma in which we find out the muscle power group of every single muscle. In total knee replacement, it helps us decide the approach that we are using: mid vastus, mini mid vastus, sub vastus. In ACLs, it helps us select the graft which we are using. This is essentially personalized medicine. This is what is medicine is supposed to be, right? And the second thing is this: find out secrets from the patient. And third is that we activate the muscles, because generally older patients will have weak quads, they'll have weak abductors, which leads to the waddling gait. So we activate the quads, we activate the abductors. This saves us at least 3 weeks of rehab. So generally our patients after a single side total knee replacement do not require physio for more than a month. Partial knee does not require physio more than 3 weeks. Because after a month, muscle fatigue starts setting in, and then that paradoxically causes pain. So we don't do physio after a month, we always give them a break. If we feel some gait correction is required, the lower back needs to be corrected, then we go back to them after a month. So this is the second reason why we benefit from the team of Alpha Ortho, is that if I want to plan a total knee replacement for a patient, the patient tells me that he's got some tingling numbness in the legs. Now my total knee replacement is not going to take that away. So our vision is that every specialty should be seen by the specialist. So we have Dr. Yogin and Dr. Gaurav here in the Kandivali clinic. We've got Dr. Ashish in Vashi. We've got Dr. Pratik in Dombivli. So any patient, before we plan for a total knee, before we plan for a shoulder replacement, reverse shoulder replacement, we make it a point in case of knees and shoulders that the spine surgeon gives us clearance that there is no problem in the spine. Because if there is a problem, that is the first thing that needs to be addressed. Without that, do not ever replace a joint. And in terms of knees, Dr. Dhrumen Sangoi, who sees that whether there's a rigid flat foot or not, because more often than not, patient complains of pedal edema after a total knee replacement. So we always correct these before we go in for a total knee replacement. So it gives you a very holistic approach. So that is how the prehab helps us. Then post surgery. Now in surgery, I know what has happened. If I've which approach I have taken, which muscle I have tenodized, how much balancing is there inside the knee, that I will convey to my physio. So the physio knows that what has happened inside the surgery. Both of us know what was there before the surgery, and accordingly we draft a plan for every patient after the surgery. After every session, they take videos, be it a spine surgery, be it a joint surgery. They take videos, they send it to us on the group. So essentially, we follow up with patients every day, even if they are not following up with us. So if we feel that something needs to be added, something needs to be stopped, if the patient is progressing faster than we expected, we stop the physiotherapy sessions or we reduce the number of the frequency of the sessions. So that is how from the beginning till the end we are able to give a personalized treatment protocol. And this is something.
Rehab also has physiotherapy.
Yes, yes. So the main examination, because we already do in the clinic. So prehab is basically pre-rehabilitation. So if the main problem after such surgeries is muscle atrophy, muscle deactivation, and that is what takes 2 weeks to come up after any surgery, especially in terms of knees. So that prehab will, so the patient knows how to contract the muscles. So they'll be able to activate it more easily after the surgery. If they're not able to do it and you tell them to contract, they don't know, their eyes don't know how it looks like. Their thigh doesn't know how it feels like. So it makes it more difficult, takes another week to activate the quads and then for them to get back to their normal life.
Good.
So that was all. This is our team.
Yes.
We have a manager, Kasuri, who takes care of the entire coordination. This is me, Dr. Gaurav from left to right, me, Dr. Gaurav, Dr. Yogen, Dr. Ashish, Dr. Dhirav, Dr. Deepak, and our two physios. So, if possible, whenever for all of y'all, I
Yeah.
would really like to invite y'all to
Yeah.
please have a
You-
look at a small clinic once.
I've seen it. It's quite modern setup, quite modern and spacious also. It's
So we
not-
made everything with a lot of care. Even
Yes.
the examination beds, we made
Mm.
sure that they are just around 20-25 inches from the ground so that a patient can get up very easily.
Mm.
Generally, patients with knee pain, hip pain tend to find it difficult when they have to get up on a step and then go up on a table. And our physiotherapy room is state of the art. We don't use any modalities in physiotherapy. Very rarely do we use a USG or IFT because these are more symptomatic treatments.
Mm.
We believe in end stage treatment. So the physio, both of our physios have been working for us for quite a few years now. So we have our own protocols that we follow, and this is basically how orthopedics is supposed to be
So
practiced.
usually, how much time do you take? I mean, your patient takes for recovery after the surgery.
After a TKR, generally it is 1 month in
Mhm.
which they get back to their normal life.
Mm.
Pain and swelling goes on and off for 3 months, is what
Okay.
we tell them.
Okay.
However, the frequency keeps coming down.
Mm.
And at the end of 6 months, they forget that they've even got a surgery.
Okay.
That is the timeline.
And the longevity of remaining.
Ideally, today's implants will last anywhere between 15 to 20 years.
Okay.
They can last even longer
Yeah.
if the amount of stressors are less. So by
Mhm.
stressors, I mean sitting down, sitting cross-legged. So you can actually do both of them. In fact, in the video, I had a small clip in which a patient was sitting down, doing yoga, sitting cross-legged. But we tried to tell them not to do it actively because it reduces the life of the implant. That is the only reason. It's not like they can't do it.
So what are the do's and don'ts after the surgery usually?
Do's is physiotherapy. Movement is the only medicine basically after surgery. And don'ts for the first 14 days is not to wet the stitches, and most importantly, don't not do physiotherapy. Otherwise, there are no restrictions.
Yeah.
Does the patient need the blood thinner?
Are given blood thinner? No. So in
After
terms.
2 or 3 weeks, some of the doctors start.
No, so what the protocol that we follow is that obviously if pre-operatively patient is on a blood thinner, we continue it post-op. If the patient is not on blood thinner, we have a particular checklist in which the physiotherapist fills during the prehab, in which we come to know whether or not the patient has potential to develop pedal edema. So we never give blood thinners for DVT because we are making the patient walk from the same day.
Yeah.
So once the calves are activated, your peripheral heart is activated, there is not going to be DVT ever. So the only reason we can give them is pedal edema. The second thing that we've started doing now is patients who have diabetes, even if their HbA1c is under control, and we tend to see some varicosities even though there is no blockade on the USG or the Doppler, we have started giving them stockings post-op. So because pedal edema tends to affect their gait and affects their mindset a lot.
Hmm.
That सूजन नहीं जा रही है, सूजन नहीं जा रही है, सूजन नहीं जा रही है. So those are the only indications in which we give blood thinners post-op, and that too we start immediately because by that checklist we come to know now that the patient is going to have pedal edema.
The patient, they don't do much movement.
Hmm.
Sometimes, we listen that patient post-operative just collapse. without any reason.
Hmm.
So is it necessary in old age patient the prophylactic purpose we should
The blood thinner?
Yeah.
No, not really. So the collapse that happens immediately post-op is
Yeah.
more often than not postural hypotension, because the patient is lying down for almost 24 hours. NBM from night, they are shifted on the bed only to the OT. Surgery is done in supine, they come back, they're lying down on the bed in supine. So when you suddenly make them sit or you try to make them stand, they will collapse. So that is postural hypotension, that is primarily the cause for that. It is physiological, that will never happen again once it happens.
And the degree of tear, as you said, the rotator matrix, that also can be judged by with the clinical exercise, or you require the MRI
So,
just to assess the degree of tear.
Grading, honestly,
Yeah.
we don't believe in any kind of grading. That is only for the radiologists.
Treatment to say.
Yeah, that is only for the radiologists.
But that makes a lot of impact on patient.
It does.
वो grade
it
4
does.
लिखा है इधर सर.
हाँ, and यही cases में हमारे diagram काम. And that is why I didn't go into the grades, because those are not necessary.
Yeah.
The only thing that is necessary in case of a meniscus tear is whether or not it is going to the articular surface. The only thing that is necessary in case of the ACL is if there is instability and the articular cartilage is intact. Those are the only things that you need to see whether
How to make
decide.
out from the imaging or the clinically whether cartilages are exposed or cracked or what is it?
So cartilage you will be able to know only on the MRI.
Okay.
That is one place where our hands are tied by the MRI and there is
Right.
superiority.
Hmm.
So on the MRI you will be able to see. I will just try and show it to you. How do we see it? So the sagittal image is basically what you see. This
Yes.
image. So like I told you, water is white. Water is white on the MRI.
Yes.
Can you see this very thin black
Yes.
line?
Yes.
This is the cartilage.
Hmm.
So you can see that there is no discontinuity in the cartilage either
Yes.
on the femur or on the tibia.
Yeah.
That means this MRI is of a very young patient, and which is why I told you the age 28 when I tried to give you a case example. Whenever there is any cartilage damage, there will be a small discontinuity like this, or there will be water over there. That is how you come to know that there is a cartilage defect, irrespective of whether the radiologist reports it or not. So even if we are planning something, even on the prescription, we always write kindly comment on the articular cartilage status. That is very important to know. We can't just go inside and reconstruct every single ACL.
And the ACL tear and repair is very common. How to? And the patients are very impatient. They get very young and they अभी से
Right.
knee अटक गया surgery करवाना.
हाँ.
That somebody had done the arthroscopy. You need the surgery. How is that? What do we see in that clinically? It takes 2-3 months for them to recover.
No, so what happens is after an ACL reconstruction, like I told you, because we do prehab, the muscle activation part becomes very easy. So generally ACL patients in our setup, if there is no meniscus tear, we start making them walking weight bearing on the same leg from the day of surgery and knee bending till 90 degree from the day of surgery. That is the only thing that is restricted for 6 weeks. After 6 weeks, full ROM. If there was a meniscus tear, non-weight bearing, anywhere between 4 to 6 weeks depending on the morphology of the tear. So if the tear is a fish mouth tear, that is a tear like this, it requires compression. So we allow weight bearing. If it is a vertical longitudinal tear, if the weight bearing happens, it will put pressure on the repair. So we don't allow weight bearing. So 4 weeks. So those 6 weeks and the prehab helps the patient's muscles be ready when he starts weight bearing. After that, he needs just 2 weeks. So 2 months, a patient is back to their normal life, except running, jogging, jumping, contact sports, deep lunges, deep squats. These are not allowed for 6 to 7 months because the healing of the graft on the tunnel's mouth takes 6 to 7 months. Then after that, they can do anything. For elite athletes, we wait for 9 months. After 7 months, we start them with proprioception training. Then field work, agility drills, strength drills, and then 9 months they go back.
We have seen is very commonly those who are occasional cricket players.
Yeah, so we call them as weekend warriors.
Okay. Yeah.
So they are the most difficult to treat.
Yes.
Reason being their explosiveness is almost as much as elite athletes, but their preparation is zero. So and they are most often than not, you will notice that they are type A personalities, all weekend warriors. So they are very impatient,
Yes.
and even before you tell them what is wrong with them, they will
Yes.
ask you when can I go back to play,
Yes.
and then they get a side eye from their wife.
Right.
So these are actually the most difficult category to treat, and that is why counseling in such patients is very, very important. you need to select the right physio for them. Physio has to be very, very strict. So
Mhm.
even our physios, we have one good cop, we have one bad cop.
Mhm.
So depending on the patient profile, we allot the physio to that
Mhm.
particular patient.
Mhm.
So we don't give them early hopes in these cases.
Yes.
So we do not tell them that at the end of 2 months you will go back to your normal life. No, you tell them to that their partner. You don't tell that to them. You tell them that for 3 months you will not be able to do anything. Then even if they say no for surgery, it is okay, because it is better not to do a surgery than a surgery failing
Yes.
because of non-compliance. So
Yes. Very nice.
prehab again in these patients become important. Generally, these patients will have very bad posture
Mm.
when it comes to shoulder, because again they do all the explosive actions,
Yes.
but there is no prep.
Mm.
So these are the most common patients that have tendinitis actually.
Right. Right.
That is caused because of impingement.
Very nice. Thank you. Any more questions from everybody?
Any TKR pre-operative MRI is a must.
No, never do an MRI for pre-operative. If you are requiring an MRI for a TKR,
Yeah.
you change the doctor.
But that
Because
is-
MRI decides cartilage status. You are doing a TKR when all compartments are anyway gone. So MRI is not going to help you in any way.
So does the type of implant, the material that you use, has any
100%. So the surgery takes 2 hours, the implant
Yeah.
lasts 20 years. So
Okay.
irrespective, there are a few patients whose hands are tied by financial means and everything, but we follow a very strict policy of not using Indian implants. We absolutely do not use them. More often than not, we use just 2 implant companies, that is Zimmer Biomet and Buccal Papas, because they have different balancing systems.
acrylic material?
No, it is nitric oxide coated, and it is titanium. So it's an alloy of titanium, MRI compatible
So they
titanium.
are the best.
They are the
they
best
the
ones. Yes.
What about Johnson?
Johnson and Johnson is also good, but it tends to cut a lot of bone.
Okay.
The same problem is there with Max, Merrill, and all that. It tends to cut a lot of the femur.
Mm-hmm.
And
So for non-affording, the metal implants are good enough for them?
so essentially the material or the alloy of the implant is same in all implants, because it is regulated by the governing body. The difference is how much is the thickness of the metal or the density of the metal inside. So if you just hold 2 different companies metals, you can feel the difference in weight more often
Does it
than not.
depend on the quality of the bone also? What
Oh,
the
definitely. So
patient
if we feel that the patient is very grossly osteoporotic, we first optimize that before doing a TKR, because more often than not that will lead to an aseptic loosening. If we feel that the X-ray shows good cortical thickness, we go in. When you saw the bone, you come to know as to how soft or how hard it is. If you feel that the tactile feeling is that the bone is very soft, you start them on an osteoporosis regimen immediately after the surgery. So because the bones are essentially, the rim of the cortex is what holds the implant and bears the entire weight. So if that is not sufficient, then high chances of aseptic loosening after that. But yes, implants are very important, and compromise on implant quality will always affect the longevity.
I'm sorry to interrupt, but looking at the Dr. Anmol has also had some understanding about homeopathy. We are starting something new from our side to the visitor specialist, and we are handing over the homeopathic remedies for different injuries. As he said, it is physical one. It doesn't require much of the history taking. And during the different injuries, what kind of the remedy you can use, that is what we have listed here.
Okay.
The most common, and what are the potency and how to repeat it. So we have given you the list. I will be giving it to you. Injury to bones and during fracture, even by surgical or by accidental. Injury to muscles, tendons, bleeding, that is from the arteries when you are surgery operated, burns, the tissues, osteomyelitis, and the nerve injuries. So during this, if you use our remedies, I hope that we have used it,
Oh,
and it
definitely.
will
I
be
would
very
love to
fast
do that.
recovery, less of painkiller you will require,
Yes.
and it will be natural healing
Right,
will be
right.
coming very fast.
Sure.
So this is one which we would like to, this is what we would like to have the feedback from them, that how homeopathy has acted into
That
their
was the
country.
last question I wanted to ask you. How does he see homeopathy scope here?
So that's what,
What is his vision?
we,
So how I
that's
see
what.
it, is that Ayurveda is a preventive science. It helps preventing a disease, and that is what even the Vedic literature says. That once something goes wrong, then you are in hands of God, but before that you are in your own hands, and that he who helps himself, God helps them.
Yes.
So that is what I understood from my grandmom as to what was the crux of Ayurveda. Homeopathy, I think it was Dr. Hahnemann, if
Yes.
I'm not
Yeah.
wrong.
Yeah. Very good.
So, based on these three principles, homeopathy, from what I know, is that the first thing it tries to do is that it makes your body try to defend itself or try to heal itself. So that is where your law of similarity comes. And the second thing is, you always treat the main symptom or the only symptom, and in the lowest dose possible.
Yes. That's what
So
single
homeopathy for
medicine.
me is something that can go hand in hand with allopathy.
Perfectly.
The
Well.
only issue that I see with that is we don't know what are the micro compositions of medications in allopathy, and as well as homeopathy for that matter. So what happens is, when we do cross therapies, irrespective of because of which medication it has happened, the burden is on the patient, and that is not something that is good. So I feel whatever helps you get rid of your disease is the best path for the patient. So if one is not working, definitely stop it, move on to the next. If that helps you, why not? There are so many cases of psoriasis. My own dad, for that matter, I've seen. So he had pustular psoriasis, he got better with homeopathy, and then after we switched to allopathy, because of his methotrexate toxicity, it completely went away. So that was actually more of a side effect of allopathy that
Yeah.
helped it
Yeah.
treat it. So like I told you, there is no medicine that is better than the other, is what I feel. But we should know when to use what, just to avoid. Yes, all three have their own limitations.
So we would like to have your feedback after using it, maybe for 3 6 months or something like that, and we want to see that how it has come out, because homeopathy initially was not practiced by homeopaths. They were practiced by allopaths and surgeons and orthopedic people,
Okay.
and they have approved all this whatever they have used. So we will recommend it to you
Sure.
also, and definitely it is good enough. Dr. Vismaya, you can come. This is token of appreciation and love from us.
So sweet.
Yeah,
Thank you.
thank you.
Thank you.
And one is for your home. That is also from my side. Thank you very much. And yes, sir. And we would like you to have sweets for you and your staff and your family.
you, sir.
Thank you very much. Please તમારી માટે વાપરજો અને which potency and how to repeat એ બધું
Sure.
we have written down there, so you can have it. And there's a just short list. We can have an extensive list, but this is a very simple one to begin with, and we would like to see that how is that is going to work.
I'll do that, sir.
Thank you very much. I hope if anybody has any queries even after this, we'll come back to and give a forward it to them. We put it that inside. And their address आपका बता दिया? Where
The
you-
clinic's
yeah, clinic address.
I don't think it is there in
It is
this.
there in the first one. जो पहला
We
slide
have
था.
our contact details.
Okay, that's fine.
That is, it's there in the other.
The first one, first slide था
Well,
आपका.
I'll just show.
Yeah. I think इसमें भी नहीं है.
So if you can just give me a minute, I'll just go through this very quickly.
Yeah.
So this is basically the vision with which
Mukul,
I
PDF Mukul.
spoke to you about how we started Alpha Ortho, and this is basically, these are basically all the subspecialties that we deal with. We are the first team in the country to have every single orthopedic specialty under one roof. So we make sure that if you require one particular condition, you are sent to the specialist. And we are primarily in Bombay and Navi Mumbai right now, along with Dombivli. And the philosophy of the super specialist seeing you every time will always remove extra investigations, start the right treatment fast.
Yes.
And this is our core team. I'll start with our spine team first.
Yes, we had Dr. Yogin here.
Dr. Yogin Patel is here with us. Dr. Gaurav Ranglani
He also
unfortunately
been
could
yes,
not be here.
Yes.
Him, Dr. Ashish, and Dr. Pratik, all three are busy. This is Dr. Ashish, who looks after a Navi Mumbai setup,
Yes.
and Dr. Pratik, who looks after a Dombivli setup.
Ashish is doing in which one?
He's in
only?
Vashi, yes. So
only
all
spine?
these four are our spine surgeons.
Spine.
And for and for pediatric we have Dr. Deepak Jain, and for joints we have Dr. Dhirav Shah and myself.
Okay.
Then these are our contact details. We've got clinics in all of these places.
Yes.
Villapalab
Vilayapala
East.
East.
Let that be on the screen.
Yes,
Take a
I'll do
picture.
that.
Yeah, that one. That one. This is the
So-
central line of yours. I mean,
Yes,
Call
yes, that is
center?
our call center.
Call
line. So
center.
every single center and which specialty to send to. Kasturi is very
I'll
highly trained
forward
for
you the personal number if you wish
Sure, sure,
to
sure,
everybody, those who are
Definitely, sir,
attending.
definitely.
That will be sending it to. તમારું બધાનું મોકલી દેશે એક સાથે. બરાબર? That's fine. And I have seen that they have been reverting back. What is your patient is going through and what is they are thinking in line of action. They've been giving us feedback.
So we very strongly believe in that. The reason I'll tell you is that a lot of times it has happened that when I've called the family physician to inform that so and so I've advised to the patient, they tell me when they tell me that they've got no comorbidity, they're not taking anything for anything, they've never taken. The family physician tells me, oh, they're an out of control diabetic,
Yes.
or they have so XYZ family issue, or they're
Yes,
a non-compliant
yeah,
patient.
yeah.
So that helps us in charting the treatment
Yes,
protocol very
perfect.
easily. And what happens is more often than not, they are going to approach you than they approach us. So to keep you in the loop is very important,
Yes.
because if they come and then if they see a blank face, then it does tend to leave a little bit of
Yeah. That's right.
hesitation in their mind.
Yeah. So, anything more?
Yes.
Okay. So, thanks for from him to give us lecture. Thank you very much. Come. So. Yeah.
Oh yes.
Yeah. Pendrive link. So, ઉદયભાઈ બેસવું છે થોડી વાર ટાઈમ હોય તો બેસો યા બેસો આવો we'll go down pen drive निकाल के we'll get it down come anybody who wants to talk